But it's very important that inhaled medications are really better. They're quicker onset, you need smaller doses, less systemic bioavailability, less side effects. And in the acute exacerbations, if the child has already been given inhaled Ventolin, don't switch to the oral syrup Ventolin, because the inhaled Ventolin is actually better. Okay, but so inhaled is better than oral, but the correct technique is very vital, and that's where time is needed to assess and to teach and to train. And from literature we know that a lot of kids and even the parents actually overestimate the child's ability to use the inhaler. So they think they know, but actually they don't really know. And according to literature, a lot of kids are actually given inhalers without the proper technique teaching or training, or inhalers are inappropriate for the child's age and use. And important to note is that delivery is very, very important. No point giving the best medications if it doesn't reach the site of action that is desired. And lots of studies have shown us that there are lots of incorrect MDI techniques used, and if you use a proper spacer, you can actually achieve much better delivery in the lungs compared to without a spacer, where it's actually deposited in the oral pharynx, where you don't want the side effects to occur. So delivery devices, we recommend spacer devices for all children till proven otherwise, and many different types for young children with a mask, older children with a mouthpiece. For slightly older children, you may be able to use a dry powder inhalers like these. And nebulizers generally are not recommended unless in very special situations. And there's really no need to use it, because inhalers are actually just as effective, if not better, than nebulizers. But what is compliance really? Compliance really is getting the patient to understand the information that you give during the consultation, and also to help them understand the perception of the drugs itself. And the steps really includes this, basically. They need to understand why they're taking the medication. They understand what happens if they're not taking the medication. They must understand what to use, when to use, how to use. And of course, in order for them to take the medications, they must understand the side effect profile. It must be acceptable to them. Ideally, no side effects, but must be acceptable. Unfortunately, in asthma medication, in between episodes, there can be no symptoms, and apparently there's no side effect or no consequence of not taking medications in between attacks. And so very often, as we've heard earlier, a lot of patients rely on the reliever medications on a PRN basis alone and do not want to use the inhaled steroids or controllers. And that is where the danger lies in asthma treatment. And how about side effects? I think in children in particular, this is very, very a great concern to a lot of parents. And as Dr. Che said earlier, I think steroids are in fact very safe in the inhaled route. And we will bear in mind the benefits versus the risks. And we know for a fact that in the literature, we know that the inhaled corticosteroids do achieve all these benefits that are a lot more than the little risks, which are actually easily monitored and very low risk actually in children on regular doses of inhaled steroids, which we often use for our children. Important for us to also emphasize to the patients, but first of all, as doctors, we need to be convinced ourselves, because if you're not convinced of the importance of inhaled steroids, you're not going to convince your patients and the parents. So inflammation is the key thing. Whatever the degree of asthma severity, inflammation is there. Okay, and it's also very important that you do not just treat just based on symptoms alone, to help them understand that preventive medication needs to continue even after the symptoms have resolved, because of this iceberg phenomenon. Because underlying the symptoms, a whole lot of inflammation that goes on. If you do not treat this, they're just going to surface again as the next iceberg peak. As Dr. Che mentioned earlier, there's long-term wise, it's actually safe. So safety is an important issue that you need to emphasize to the patients. And very often we talk about height growth and things like that. And basically, poor asthma control, as we heard earlier, can actually impair the growth more than the treatment itself. And sometimes you may see a tapering off of the growth of the height of the child in the initial asthma disease itself. But once the asthma is well controlled, you find they actually catch up and reach adult expected heights. And so there's actually no reduction in the final adult height in a child that's on low to moderate doses of inhaled corticosteroids. So we know that monitoring is very, very important for us to achieve the desired goals. And we want to achieve the controlled state of the child's asthma. And these really are the goals of our asthma management. And we need to focus on this. And that overall is the focus of our new CPG guidelines. Very importantly as well, a lot of our classification or evaluation in our clinic is based on symptom perception, symptoms reporting. And that again is another very important thing, because very often asthma symptoms can be found to be very inaccurate in a lot of children and even in the parents. Of course, yes, some will over-report, but a lot of them do under-report the symptoms as well. Under-recognition is an important factor for increased morbidity. However, it's important to bear in mind that accurate symptom perception is the first step towards appropriate response and therapy. So we need to teach them how to recognize the symptoms and also to be able to pick them up early enough. And this is the asthma action plan that we use in our NUH asthma clinics. We run the program called the ICANN, or Children Asthma and Allergy Network. And basically the focus is to help the children and the family achieve control of the disease and don't let the disease control their lives. It's just a close-up of the action plan itself. This is what we do here. Maintenance treatment, when child is well, mild symptoms, you step up the medications, add on whatever, and symptoms get worse, you add on all these special instructions. And because a lot of our kids are looked after by their foreign helpers, as Yap Chuan mentioned earlier, we need to have stickers and visual aids for them. So we've actually produced stickers like this with the shape of the inhaler, the color, so that the helpers can actually then not mistake Morphine or Bygone for Ventolin. They're all blue in color and they're all sprays. And so it's very important to help them as well along the way so that they don't make mistakes in here. So the ACT is what we also like to emphasize, and the concept of treating to a target. As we have heard earlier, this concept is very well established in hypertension with BPs monitoring, hyperlipidemia, lipid levels, hyperglycemia, and diabetes. But in asthma, it's a relatively new thing. We're the newcomer to this new scene, this old scene basically. And the asthma control tests, as we've heard, have got different versions. And for children, there's a version for 4 to 11-year-olds, and for the older children, more than 12-year-olds, one is just 5 questionnaires completed by the patient, whereas the younger ones have got a portion by the parent and a portion by the child. And so if all of you have picked up a copy of this along the way in, you've got the childhood version of the ACT in here. It's very simple to use. It's a good objective test because it's validated. It involves participation of the child. So when you actually answer questions, you think about it, then you realize and be sensitive to the changing symptoms you have. Very convenient, and it's very useful for your clinical management. So this is the example. The ACT is available online as well at the asthmacontrol.com and also at our icann.com.sg, our ICANN website. You can also access the same ACT. So this is the ACT for 4 to 11-year-old kids. The first 4 questions are completed by the child, and the next 3 questions completed by the parents, and the aggregate score maximum of 27, and we use a cutoff of 19 again. And this is the ACT for the older children more than 12 years of age, completed by the patient themselves, just 5 simple questions. Very easy to use. So basically you can see that asthma care in children actually requires a partnership between the child, the parent, and the healthcare professionals. It's not just one person itself. And I know that and recognize the fact that it involves a lot of time and effort to do this. But you really want to achieve optimal outcomes in the child, you really need to invest in all these, because if not, you're just not going to get the best outcome for your patients themselves. So asthma management is really way beyond just medications. You need to take a holistic asthma management approach. So you need to educate them, you need to empower them to achieve control of the disease itself. You need to enable them to control the condition through the use of the action plans, to encourage them to exercise, to encourage them and help them to understand the importance and how to achieve compliance in treatment. And really, ultimately, the goal is to enable every child to lead a normal lifestyle and a good quality of life. And so let's revisit this whole thing again. Right, so after diagnosis, medications, allergen avoidance, trigger avoidance, education. So these are the key things in education that you really want to highlight. The child to lead a normal life in terms of exercise participation, normal dietary intake, appropriate allergen avoidance, correct inhaler techniques, good compliance, good understanding of things, good symptom perception, and very clear goals in asthma management so they know what you're trying to achieve for them and they can reach it themselves. All right, so thank you very much for your attention.